Tell me why I don't like Mondays. Tell me why I don't like Mondays.
So tell me why I don't like Mondays. Well, love them or hate them, they're the start of the week, and that's a great time to think about new ideas. So welcome to this, a new series called the Perioperative Coach. In this series, we have top tips on all aspects of perioperative care from some of the world's experts working together to enhance surgical recovery. Don't forget to look on the show notes on topmedtalk.com for additional links to papers, etc. And of course, if you haven't done it already, subscribe to Top Med Talk. Top Med Talk. So how are you keeping the pain away? Joff, Mike, what did you hear in the general discussion about how this sort of pain relief is provided for these patients?
I think the pain one was probably the most was the talk that got most amount of interest from the audience. I think it's because it's obviously something that is dealt with. It's a common problem really with our inpatients. I think the term I really enjoyed looking at and hearing more about was the optimal analgesia. That we shouldn't be targeting patients to be pain-free. I mean, obviously, if they are, that's great. But you should be achieving as little amount as pain that allows the patient to return to a reasonable amount of function, and therefore you can minimise the side effects. And I think that term of optimal analgesia is better than that target of going, right, we've got to, they're in any pain, we've got to give them more pain relief. And that was quite impressive. And as you can see that from the 3-dial infographic that you described. But yeah, it generated a lot of conversation and interest. Everyone has their different recipes for how they deal with pain in the perioperative period, and there are lots of ways of doing it, and not everyone agree. But I think generally there was this overwhelming agreement that we probably aren't doing enough a lot of the time, and that there really needs to be a true perioperative approach, that you really do the best you can preoperatively to give patients, load them on simple analgesics, to have a target of almost no opiates, not just opioid sparing, but no. We use too much opiates; they're not good. They have far-reaching effects outside of the inpatient stay, and there is lots more that can be done. And things such as lidocaine infusions and ketamine infusions, which are in the places I've worked in the UK, are very rare, if at all. But there certainly seems to be a growing trend here in the US. Is that right, Julie? It seems to be quite a few units of the people here saying they use that almost routinely. So there's a lot that can be learnt from the cross-pond discussions. So it's been great.
And the opiate, because we've been having quite a guilt trip recently as people involved in major surgery, that perhaps we've been inadvertently drivers of some of the opiate addiction that comes up after major surgery. Was that discussed? Because looking at the slides and looking at the recipes and all the discussions, it seems to be very, very light on opiates, on morphine type of drugs, compared to what we were historically used to.
I think that's been a fairly major theme, not only of this particular session, but also the introductory talks. As just certainly in the United States, one of the major background contextual factors is this, if you like, epidemic of opioid use, which may in part be attributable to operative use, which is being continued into the post-operative and then domestic setting, and very much the emphasis of the Pokey manuscript, which I think is very nicely illustrated in the second diagram, is avoidance of opiates, focusing on the whole perioperative journey, and then using a mixture, multimodal approach for the rest of your analgesia, so you're minimising the side effect profiles from a variety of drugs working together.
And all those recipes and all the proposals, there's a pain 1 and a pain 2, there's the initial bit and there's the journey to home, are all in those excellent papers that can be found online. Top Med Talk.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.